challenge in this whole thing is that we often don't have an easy framework with which to make sense out of the kind of disagreements and challenges that we're seeing within families and between family members. So I wanted to try to offer not a solution necessarily, because I think every situation is unique, and there's not like, oh, just do this and the disagreements will go away. I wish it were that easy. But just maybe a way to think about them and to get underneath what the disagreement is really about sometimes. And so the first thing I would say is that disagreements are normal, natural, expected, and can be very important because they can sometimes open up things that we wouldn't know about or wouldn't be exposed to. And in the course of daily living, people disagree all the time. And families that are disagreeing in our offices, you know they're disagreeing at home. And so it gives us data that we can use constructively. But the reality is we all dread it. You know, we don't like it when parents are disagreeing in our office. It creates a lot of stress for us. And so I wanted to spend a little bit of time trying to think about why do we dread it so much if we think it's a normal, natural thing, because people have different opinions and different perspectives and different lenses through which they're seeing things. So we should be aware that they're going to see things differently. So next slide, Barbara. So when we think about the reasons we dread them, the first thing is that the reality is it can slow us down. And we don't like, in our busy practices and your busy practices, we don't like things that slow us down, just as a general rule. Whether it's a complication, a medical complication, or anything else, it's going to slow us down. Next. Sometimes what happens when conflicts arise is that it can create strong emotions in the office amongst the parents. That can slow us down because we have to manage the emotion, and it can also make some of us uncomfortable with strong emotions. That's not why we necessarily went into medicine. We didn't go there for the affect. We went there for the science and the ability to affect health change and things like that. And so not everybody is equivalently comfortable with strong emotions. And so that's another reason it can slow us down if we don't feel skillful in managing it. Next. Sometimes there's a situation where we find ourselves agreeing with one parent, or we want to agree with one parent, or we feel a parent pressuring us to agree with them, and this issue of sides. A triangle, in the world of psychiatry, a triangle is a very unstable shape, right? So if you have two parents and a clinician, that makes a triangle. It's inherently unstable, and the strongest bond should be between the two adults, the two parents, not one parent and the clinician. Sometimes that's not so possible, but it can be. You have to be extremely careful about whether you're aligning more with one and how that could impact the conversation you have with the other. So that's difficult, and without real training in how to manage that, it can be very uncomfortable. Next. And then we all go into this because we want to help kids do better. And the reality is parental conflict is a bad prognostic factor for children across the board. So we don't want our kids that we're caring for getting caught up in the conflict. And sometimes the conflict leads to delayed or absent treatment or demanded and unnecessary treatment. And that is bad for kids. And as child-focused clinicians, we don't like that. So there are probably other reasons that we can dread them, but those were some that I thought were worth mentioning, because I think they're fairly common and very reasonable for us not to want to go down this road. Next. So when do we encounter conflict? We encounter it whether sometimes is there a problem, yes or no? What we think is a pretty straightforward question can turn into 50-plus shades of gray, if you will. What's the diagnosis? There can be a disagreement there, and then what to do about it. What kind of treatment planning? What kind of type of treatment? The sequence of treatment? What are the target symptoms that we're supposed to be working on? All of those can have disagreements. Next. So when we see disagreements on defining a problem, we see a variety of things. One is like, oh, I was just like this when I was that age, which to me means I am perfect. It's sort of like, I'm going to give you what parents will often say and then what I hear in my head, okay? So when I hear a parent saying, oh, I was just like this when I was that age, even if it's not I am perfect, there's nothing wrong with me. Are you suggesting there's something wrong with me? Because I was just like that. And so that can be an issue. Next. There's nothing wrong with Johnny, which to me says, I have a perfect child. How dare you tell me something else? Next. Johnny's fine when he's with me, or you can't handle X. And you see this with parents who are having a lot of conflict or maybe divorced. And that's basically saying, I have perfect parenting skills and probably a perfect child, and you, the loser parent, does not. It's your fault, not the kid's fault. Next. We see this too. Oh, Johnny just has a terrible teacher, which I hear as, I have a perfect child, therefore it must be someone else's fault. And next. He's just bored at school because he's so smart. I have a perfect and a genius child. Next. You're never here, so you don't see what I see, which is you're clueless, incompetent, not invested, all other kinds of negative comments. Next. And Johnny's scared of you, that's why you don't see it, which is you're not a perfect parent. Next. And so on. Okay. Now, hopefully some of those are things that you've heard or some variation of those. Has anybody heard anything like those?
Yeah. Oh, yeah.
Yeah.
All of them.
Yeah, and there probably could be more that we could come up with, but I think what I would think about, ask you guys to think about, is when you hear parents saying that, try to think about what is the message that this parent is really giving me. For most of these messages, it's a very defensive stance, because having something wrong with your youngster is, and I'm going to use this word with a small n, a narcissistic injury to a lot of adults. And I don't mean that like as in a personality disorder, but it's, I have felt somehow that in such a way that my child is now having problems. I must be a bad parent. I must be a bad person. I haven't parented him well. It's my fault somehow. And most of us don't like feeling like that. So a lot of these kinds of statements are a way to extrude that feeling of being a bad parent. And so I would just challenge you all, when you're hearing those things, to think of it as probably we're hitting on a nail on the head that a parent is struggling with that concept in some way. Unfortunately, we also see parents who use these kinds of words against each other, you know, hopefully these are the kinds of things that we're going to keep talking about. Okay, next. So how does this happen? Next. Parents spend differing amounts of time with their youngsters. Next. They have different roles when they're with the youngster. Next. And they have different prior experience with children. You know, sometimes we see families where they have children from a prior marriage where none of that went on. Other parents, it's their first youngster. And I think fundamentally people can have different perceptions of how to define a problem. And I think I want to talk through the difference between categorical and dimensional reasoning in this situation. So next. So when we think about categorical or dimensional issues, categorical is basically it's separate and distinct. You either have it or you don't. You have cystic fibrosis, you are pregnant. There's no in-between. Next. Dimensional issues are continuous variables. So blood pressure, optimism, intelligence. Optimism is, you know, we know some people that are more optimistic and some people that are more pessimistic. That's just a trait. IQ. Blood pressure is a continuous variable that we then impose a categorical decision that, oh, above this line, and the line keeps moving, you now have a disease, a categorical disease called hypertension. Below that line, even though it's a continuous variable, you no longer have a disease. Next. So I'm just going to use ADHD as an example to walk us through, but you could put depression, anxiety, you could put a lot of things there instead. So what makes us think that ADHD has disease-like qualities? Well, we know that there's a genetic basis to it. Family, twin, adoption studies, association linkage studies tell us that. We don't really know exactly what the genetics are, but that's okay. We don't really understand a lot in the world of psychiatry, how the brain works or genetics and things like that. But we do know that there's a genetic vulnerability to getting ADHD. We also know that ADHD as a disease is associated with some specific brain disorders, Fragile X, fetal alcohol, other kinds of things like that. So we know that there is a brain-based genetic quality to it, which lines up with other diseases about which we may know more about the pathophysiology and the genetics and things like that. But that's okay. Next. If we want to think about ADHD as a dimensional issue, well, the reality is we all have a certain amount of attention span, and a focus. We all are some degree of active, and we all are some degree of impulsive. It might be very low, might be very high, might be very low active, high active. Some people who do not have the disease, ADHD if you will, have really good attention, and other people don't have really good attention. And we all know people that would fall somewhere on those spectrums. Next. And if you could map it out, basically, no, go back. Everybody would be on a normal distribution curve if you could map everybody's traits, if you will, optimism, pessimism, thrill-seeking, risk-averse, shyness, gregariousness. All of those things are human traits that are continuous variables that map out. And attention, activity, and impulsivity would also map out on those as dimensional qualities. Next. So here, this is called hyperactivity dilemma. On the bottom, you could have hyperactivity. You could also have low mood. You could have worries. You could have attention. You could have impulsivity. It doesn't really matter what variable you put there, because what I'm going to show you would be the same regardless. But if we look at, say, hyperactivity, there is a small normal distribution curve of people who are very, very, very hyperactive. Okay? And they're the blue people that live there under that curve. Next slide. Those youngsters are at the tail end of a normal distribution of hyperactivity or overactivity. And they represent a subgroup of those youngsters who are at the tail end. Next line. When we discover treatment, and again, this could be hyperactivity, attention, low mood, worries, whatever. When we develop a treatment for something, we try to set the severity of threshold for treatment to be in a place where everybody to the right of the line will get treatment. That way we know that everybody to the right of the line is falling under that small curve. It shouldn't be pointy at the top. I don't know how to make it not pointy on top. It should be a normal little curve. Okay, next slide. But as clinicians, when we have a treatment that works, we like to move the line to the left so we get more people under that little curve, the blue people, into treatment. Next slide. And we continue to push that line because we want more blue people treated. Next. Next, yeah. Unfortunately, this is the line that we wish we knew the slope of, but we don't, because now we would be treating essentially only blue people. Next slide. But we're left trying to draw the line somewhere here to think about treatment. Next slide. Oh, wait, go back one. So the problem is, when you look at this slide, we, are not treating all the people under the little curve, which is one category of problem, but we also have people who are not under the little curve, but are under the big curve, who are getting treatment. That's kind of an issue, because those people are probably phenocopies of whatever it is under that little blue curve. So whether it's hyperactivity, low mood, depression, anxiety, whatever you want to think about it, some people are getting treated who don't have the categorical problem or medication responsive. Okay. So does that make sense?
Yeah, it's a great way of looking at it.
Okay. Any questions about that?
Nope.
No? Okay. So I'll just, as a little aside, sometimes people will say things like, oh, we are over-medicating our youngsters. To me, that's not the right question to ask. The right question should be, are we medicating the youngsters? Because a lot of kids under the blue curve are not getting medicated, and some kids under the big curve are. So we have the wrong kids potentially getting medicated because we don't know the slope of that line. Years ago, I had a medical student say to me, well, why don't you just figure out the slope of the line, and then what's the big deal? Like, okay. Welcome to reality. We just had to do that when we're actually caring for humans.
Although I would say that some of the move towards personalized medicine and genomics, we may actually someday soon be able to draw a line that does look more like your line on a slant. Because the problem is what knife we're using. If we only have a knife that cuts straight down, we're going to be stuck with this kind of model. But if we can combine characteristics, we may actually get to the point where we can identify the right people better.
Well, you're more optimistic than I am. I fall at a different place on the curve than you because I don't think that'll happen in my lifetime, but you never know. Okay, let's go to the next slide.
You're younger than me, so.
Let's go to the next slide. All right, so the reason I just went through all that is because I think this is a fundamental issue that can lead to disagreement. People understand the problem differently, they perceive the issue differently, and that leads to different beliefs about its form and function and different approaches to managing it. If you think something is a dimensional problem and they're just at the tail end of the curve, that's not a categorical disease that needs fixing. It's who somebody is, not what they have. That is, I think, the etiology of some of the significant conflicts we see in families because they are understanding the problem differently. Next slide. So what do we do about it? So it's really important to understand whether people are taking a dimensional approach or categorical approach. Next. Because both are important, okay? And I think it allows us a way to validate both perspectives that parents are presenting potentially. If one is taking a categorical approach and one is taking a dimensional approach, they are both correct. And that is a much nicer place to be than having to say one person's right and one person's wrong. They can both be correct, and if you can educate them to be able to see the other perspective, that can be powerful. Next. Okay, so then I usually try to think about what I sometimes refer to as visioning, which is asking parents, what do they each want for their child? Most parents, there are a few truly malignant humans. Most of them, though, don't come for help, thankfully. So we're not usually dealing with the most malignant of parents. So most parents will say something like, I want my youngster to be happy, healthy, and successful, however they define that. And usually that will be pretty similar between the parents and pretty easy to align and join with both of them, and for them to see some commonality. Next. So then you can go to, okay, well, what seems to be getting in the way to your child being happy, healthy, successful, making friends, doing well in school, feeling happy with themselves, things like that. What seems to be getting in the way? Can they identify what it is that's getting in the way? Next. And can they imagine, this is the visioning part, can they imagine overcoming those barriers? What would that look like for them? Can they even, sometimes parents can't even imagine it. It's just so far out of their perspective that they can't think about it. And sometimes they need some help imagining what that could look like. Next one. And then I talk about, can they ever imagine needing an intervention? What might that look like? Can they, if not now, when? What would that look like? Next. I think it's also really important then to focus on impairment, if there is any, and there may not be, which makes this a little bit harder. But is there impairment now? And what can you project that there may be impairment down the road? We know that youngsters who are having trouble making friendships are going to be increasingly rejected by their peers when it comes to middle school. If they're having trouble in elementary school, they're going to be rejected by middle school. And middle school is all about your peer relationships. Next. And this is when you get to introduce your knowledge and expertise. You can refer to the literature, refer to experience. You are experts and you have a lot of knowledge. And I think when you do this kind of visioning activity, it can allow a lot of their questions to be on the table, and then you get to be knowledgeable and wise. And I think that can be a nicer place to be than in the middle of an argument. Next. Okay, so when I talk about what are the obstacles and what can they imagine, these are the kinds of things I'm talking about. How many courses or subjects or whatever do they think that their kid would need to do poorly in and have teacher concerns before they might want to intervene? And I'm focusing on ADHD here, but you could change the words to any psychiatric problem. How many? And I'll sometimes say, Johnny's failing math right now, and I hear you saying that you don't feel that that's that big a deal. You weren't good at math, and so it's not going to be his thing. Are there if he were failing more subjects, would that make you feel differently about it? How socially disconnected does your child have to be before it seems like an intervention might be abused? So I hear you saying that the mean kids at school are picking on him and giving him a bit of a hard time, but that you're okay with that because they're horrible kids anyway, and you don't want him to be friends, and he has this one other little friend. Okay, well, could you imagine like what it would look like at school where you might worry about his social connections? So you begin to just push a little bit on the defenses they've put up, if you will, around why they don't see it as a problem. And how will they tell if their child is making progress? What do they look for? How will each person tell if things are getting better if you're not going to do anything? What will that look like? And I think we have to ask parents to do the work of visioning so that you can see where the flaws are in their reasoning. And sometimes they can begin to see that they're not really making that much sense. Next. So that's if there even is a problem, which is in some ways I think the biggest hurdle. If you can get them to disagree about treatment, it means you have been successful in getting them to agree that there's a problem. So already it's a much better place to be, even though it sometimes can feel just as bad. But it does mean that they have a shared belief that something needs treatment, and that is a critical anchoring reference point that you can go back to when they're not agreeing about treatment. So then they're stuck about what to do. I try to fall back on, help me understand what it is that makes you uncomfortable about meds. Help me understand your concerns about your youngster going to weekly psychotherapy, CBT. What is it you're most worried about? And give everybody some floor time to understand what that is. Sometimes they have misinformation about what it is we're really asking them to do. So we go to the next slide. When we see disagreements about treatment and we say we want the family, again, I'm thinking, coming from an ADHD standpoint, but this could apply to almost any kind of problem. Parent management training, well, who's going to do the work? Okay? Is everybody really at 110% of themselves, and are they ready? Because they might be saying, we can't do PMT, and the parent is saying, yes, we can, because one parent knows that he or she is a little bit depressed and isn't up to the task, or is going to be traveling, or has a big work stress coming up, or whatever it is, has an adult parent that they have to look after, and knows that they're not really able right now to be at their best to do that kind of work. And they would rather say, no, let's not do it, than fail at it. So there could be lots of reasons why you're hearing the no's, and we have to sort of unpack that. I will often say to youngsters that, look, you have harder to parent. Your kid is harder to parent than the average bear. You are going to need industrial strength parenting skills, and that's going to take you being at 110% readiness. Are we there? If we're not there, let's work on getting there. And what do we need to do? And maybe the kid's behavior is going to continue to be bad for a little while until we can get the parents ready and feel like they are both ready, or whoever it is that's going to be doing it, to move forward. Next. Maybe they don't agree about individual therapy. Well, maybe they don't know what therapy is. And the reality is, I would say that a lot of families have no idea what therapy means because there's a lot of bad therapy out there. There's a lot of come back every week and we'll chat. Well, to me, that's not treatment. It might be important if you're doing very intentional supportive psychotherapy, which is a thing, but it has parameters, goals, and expectations. So we have some work to do with our families to help them be educated about what evidence-based treatments are out there, CBT, IPT, other kinds of PCIT, other kinds of things that can be helpful, and we have to help our families be educated about what to look for in a good therapist, and how should they be having homework? Should they have, how many sessions should it be? How do they know if the kid's getting better? What are the expected outcomes? What's the timeline for that? We need to provide some structure and guidance so that it isn't just kind of a free-form thing about which they're disagreeing. Next. And then very commonly we see parents who disagree about either the use of medication at all or the use of a specific medication. And the way I try to think about this is that often families will have a belief that once you start a youngster on a psychiatric medication, they're on it for life. And I think that's a common belief out there in the public in general. And it's very much not the case. So I try to talk to families about, look, we are going to think about trying a medicine Well, I do a couple things before I get to that. I do, okay, this is where your kid is right now. These are the symptoms that you have brought to me as a concern. We've agreed on a problem. These are the symptoms that are concerning. Can't finish his homework, can't sit in a chair, distracted, always ends up in the principal's office because he talks out of turn, that kind of stuff. How will you tell if by not using medicine and not doing parent management training, how will you tell if anything is getting better? How long are you willing to wait? What are your outcome measures that you want to look for? Okay. Or say they want to do psychotherapy first. Okay, well, what kind of psychotherapy? You're going to do PMT. How many weeks? How will we tell if it's working? And what will the next step be if it's not working? Because if it's working, that's great. Okay, at what point do you feel like medication might be able to be considered? All right, then what I have here is there are two levels really to informed consent and decision-making about medication. The first is, are we willing to try a medicine? It's just a trial. It's X number of weeks. These are the symptoms we're going to look for. These are the side effects we're going to watch out for. And this is how often we're going to check in about it. If we don't develop such terrible side effects that we have to stop regardless of the outcome, if we get to the end of that trial period that we agreed on, then we're going to have another decision. The first is, did it make any difference? If it did not help the youngster, the medicine will be stopped. If it did help the medicine, then the grown-ups get to decide, do we want to continue it or not? They get a second chance to change their mind or to continue. And really at any point they can stop giving the medicine, and we know that there's terrible adherence out in the world. But I think it's really important to think of that first pass at the medicine is we are trying it for X number of weeks, and then we're going to make a new decision. I have seen families who didn't understand that and just thought it's now and forever, and that can be a very helpful way. And even a reluctant family member can come on board if they know that it is time limited and that they get to get their voice heard again at another point in time that's been agreed to. Next. So this is really my last slide. I really wanted to think of disagreements, to reframe it a little bit, as opportunities to move treatment forward. When we see disagreements, there's a lot of data gathering that happens in those moments. We see what it is the parents are doing with each other, how they get into conflict, how that may be impacting the youngster. We do need to address them, but it can also be a pivotal moment in your relationship with youngsters and families when you can make a disagreement turn into a constructive movement forward, and not just the disagreement, and that's the stop period of the conversation.
This lady that told me she was a Google expert said, well, we filled out the Connor scales, and he only has 5 of 9 criteria, so he really doesn't have ADHD. And I went, well, he's subsyndromic, but he's still in problems. He's failing 3 classes. He's getting in trouble. You're getting called 2 or 3 times a week, and he's living half of his days in the principal's office.
Mm-hmm.
So we finally convinced him to try the medication. Now he's got 4 symptoms on follow-up. Well, he's still a problem. He's a subsyndromic problem.
So in that kind of a situation, I would do a couple things. One would be I would say, you know what, Mom, you're right. You are right.
That's what I told her.
Help me understand, are you worried about the trajectory he's on? Because I'm worried, but are you worried? And have the discussion more about the vision and what she wants, and is this getting in the way of him getting to where she wants? Now, it's also possible that she's correct and that the reason the stimulant isn't working is because he actually has something else. Maybe he has anxiety. So I think sometimes it's important for us to say, oh, maybe the parent's right, and they're not agreeing with us because they know more than we do about their youngster. And sometimes that is the case. Sometimes it's not. We tend to be knowledgeable, but sometimes we get it wrong. And so I'm very comfortable being wrong because it happens a lot. And I'll just say, okay, well, if you don't think it's ADHD, is there something else that you're worried it might be? How do you explain this then, that he's having such trouble with his normal developmental tasks? And maybe that can sometimes lead me to new data that I didn't otherwise have.
I just wonder if we can go back to the insult to your ego that you started talking about a little bit at the beginning.
Uh-huh.
You said it was a defensive narcissistic injury. So I had a kid last week who I diagnosed for the first time with Rett syndrome.
Oh, goodness, that's terrible.
Yeah, which is rare and a horrible thing to have.
Yeah.
But the father came in really joking around, and the mother happens to be a nurse. And so we had a difference in sort of knowledge of medical things and child development that came from her own background, as well as all those other things that you said in this talk about her exposure, her role.
Mm-hmm.
So what I said to the father, I said, this is really hard to hear, and I made a sexist comment too. I said, it's often especially hard for fathers to think about there being something wrong with their kid. And he broke into tears, which was a real breakthrough in the session, actually. But I wonder whether you have some other strategies for that narcissistic injury, because I think that's what it was in his case. He couldn't.
The other thing I think we sometimes forget about is that, as parents, all parents want their child to be perfect, and no child is, which is a pretty remarkable conundrum for all parents everywhere in the world, right? And there is, I think, particularly when you come to grips with, a diagnosis like Rett's, which is devastating, I think we have to respect the grieving process for the loss of the perfect child they envisioned. And you see this certainly in families who lose pregnancies or have stillborn babies, things like that. And in those circumstances, we tend to be mindful of grief. I think to give a child a diagnosis of Rett's, or to give a child a diagnosis of teenager, an older teenager, a diagnosis of schizophrenia, we should similarly anticipate, prepare for, and support the grief that a parent needs to go through in a process. It's not like we grieve it and then we move on. It's a process for parents, because it's coming to terms with that child will never be exactly what that parent had hoped for. And whether you want to call it could be a narcissistic injury, but it's also, I think, grieving is maybe an easier way to wrap your head around it. And I think sometimes we forget to do that for parents. And so that's another frame that I will sometimes take, which I will say, I'm guessing that it's pretty sad to, as you envision your youngster's future, this news is going to change what that looks like for you, and that's a sense of loss. And to be okay with them being sad about that, because it is a loss, it is a grief, and I think we don't give parents enough time and space to have permission to do that when their child is still alive and doing stuff, as opposed to if the child passed, when in those situations we do give them permission to be grieving. I think particularly around psychiatric dysfunction, because so much of it is relatively invisible. It's not completely invisible, I would say, but it is often relatively invisible, that people don't, it's different than pushing your child in a wheelchair with bad cerebral palsy, because that other people can see and they can make some sense out of, and often generates empathy and sympathy. Having a mentally ill youngster doesn't do that so much. And so when that autistic child is having a meltdown in the grocery store and everybody else is staring at that parent in rage because, gosh, can't you control your kid? That's a grief moment for a parent, as well as a frustration moment and a distress moment and an exhaustion moment and everything else. But I think that that's a grief moment. All those times that happens, it's a reminder to the parent that their child is never going to be what they had hoped for.
Emily, I also really appreciate your perspectives here. And sometimes in pediatrics, probably more in child psychiatry, you're in the context where you can see you have both parents in the room and the kids in the room. And there's some disagreements, and you really want to get into understanding the disagreements, but you got the kid in the room. And I think that you have to decide in how you get them to talk about it, because this is some of the perspectives, if you really go further, can be hurtful to the child. So I think maybe we don't take an opportunity to, or have strategies to have the child there and not there for the purposes of airing some of these and understanding them further, because parents are holding back, and they should.
Yeah. And sometimes you need to say, I'm wondering if we should meet separately.
Yeah, I just wanted to comment on this particular case of the ADHD treatment, which was a close case example for you and Jerry. I find, and Barbara and I do this placebo dose finding trial that I start every patient with ADHD on that. It does make it really clear that this is as Emily said, this is a time-limited trial. These are the goals. I find it hard when they have also different perspectives there to get accurate information at the end of the trial. Because what I find we always do this. We do placebo, low dose, high dose, placebo, low dose, high dose over 6 weeks with weekly teacher and parent ratings. So where the disagreements come out is when on the placebo weeks when they're frightened. And I had recently one father reported in all kinds of sad and even kind of hallucination episodes that happened. It was clearly on the placebo week, and this father was looking for stuff like that.
What did you think of Emily's discussion about maybe this isn't a time that you as a family have the energy or the strength to actually participate in therapy or to get your kid to therapy?
Well, we have a huge problem. I mean, this is largely low socioeconomic class families, and we have a hard time getting parents to buy in to treatment period as far as even showing up. We have a community support program, and they rely on the caseworkers to do most of the stuff that normally a parent would do. We try to involve them more, but our huge problem is that our parents are largely not involved in the kid's life.
And what would you say about what gets in the way of them being involved and being able to envision themselves as part of what's necessary for the kid to do well?
From our standpoint, what we see, not to assign blame, but a lot of times it's a kid raising a kid. A lot of times the parents are on drugs or alcohol. A lot of times they work. You have the working parents, and they, quite frankly, if they miss any more work because of the kid, they're going to lose their job. Mm-hmm. It's just a myriad of things. Maybe they have 5 more kids at home and they can't come in. It really is it's a mix, and so we take each case separately and try to do as much problem solving as we can and try to get them involved. But I don't sense that it's really a lack of caring or lack of responsibility. I think it's more of a lack of knowing what to do or knowing how to get there type situation.
Mm-hmm. Yes.
So mine is a little bit different than what you were just talking about. The area that I work in, very, I would say, way upper middle class. So in referencing back, I have the Google Doctor parents who come in and this is what's wrong with my child. This is the medication I want them on. This is the dose that I want them on. Mm-hmm. And it's a very different dynamic than what you guys had talked about with then when we have divorced parents. Again, I had mentioned that before. I mean, even where parents have taken each other to court to say that, yes, they need their meds. You have to give them their meds. The one thing that I do find interesting is that when you mention the word mental health, because we're pediatric primary care. When you mention the word mental health, it automatically, they just want to shut down. They don't want to go to a mental health provider. They want their primary care to handle it, whether it's for insurance reasons, whether it's a stigma they're afraid that their child's going to get. So for different reasons, other than what you were talking about, Amy, of affordability or parents being more active in their child's care, ours is a little bit different, but it's kind of the same issue that we come up with, especially when we're treating for ADD, but then there may be the underlying factor of anxiety or depression where we don't treat that, and we feel we do need to refer them out, and that's where sometimes the parents can disagree, even in same households, and that's where it's hard to get both parents to come in so that there is that triangle to discuss, this is the issue with your kid, this is why we feel that way. It always seems to be a phone conversation.
Well, what we've done in a lot of cases is we've actually put mental health professionals out in our primary care clinics, be it pediatrics or adult medicine or whatever.
Mm-hmm.
And interestingly enough, we have the same problem there too. We have trouble with them coming. I mean, like I said, we've tried just about everything we can, including taking people to the home. I mean, it's just like, well, we don't want to acknowledge that that's a problem, and again, I'm not casting blame. I don't know, but that's what it feels like.
It does.
How about the role of the school?
I think the first thing is you have to remember we need permission from parents to be able to speak to the school. So that often is not a big deal. Occasionally, families will say no, so that's a really important first step. The second step is I think it's incredibly powerful to pick up the phone and call and ask to speak to the student's teacher. Teachers, I know from my own experience it's very easy, like when I'm attending on the inpatient unit or working in a clinic setting, it's very easy for us to think, what is wrong with the teacher? Like, really, get it together, teacher. How hard could this be to fill out the Vanderbilts, get it, whatever. And it's very easy, I think, to lose sight of what that other person's set of responsibilities are, tasks are, challenges are. And so I think it's really important to have a call, if you can, and find out that person may have 45 kids in their classroom, and the youngster that you're concerned about is one of the best ones. So it can be very important, I think, to establish a relationship and a connection and hopefully a collaborative team connection, like we're in this together to try to figure this out for Johnny or Susie or whomever. And sometimes you can get that just with a phone call. Sometimes you can't. And sometimes the school agrees with that there's a problem but doesn't have the resources to fix it, agrees but doesn't have the expertise or know-how to do anything about it, and they may not agree because in that setting the youngster may not be causing a problem, or that setting doesn't have the kind of expectations that's going to pull for the problems that you're seeing in other contexts. So I think for me, everything we do is relationally founded, and so I think it's extremely powerful for a teacher to know that they have an ally and a partner potentially in their child's PCP. I think that's a really useful thing to do.